Okay, so we've spent all of this afternoon with some 250 people who gave us most of their day to come and talk about what they thought about the NHS, what their experiences were and what they thought we could focus on. We've had really exciting conversations. We've had people who work in the NHS, people who work in social care, we've had carers, we've had patients, people who use services, people from local health watchers, people from voluntary organisations, all bringing a really rich and diverse set of views and experiences to help us inform what it is that we need to do moving forwards. With me are people who've been in all of those workshops who are going to share with us some of their key reflections and some of their key things that they want to feed back, because this is really important. These key reflections we want to come back to when in March next year NHS England will be holding an expo. So there'll be more about that as we move forwards. But I would like to thank Malcolm for the opportunity to do this today and to bring these voices and views into this space. So can I start, please, by asking Paula and Kevin to just give us their summary reflections on some of those conversations you had in your workshop today?
I'd like to start by saying thanks for the opportunity to do this. It's different, but it's very good. In our workshops, what we did today, which was around health and equality, there are a great number of points that came up which were really valuable, but we agreed to bring them down to these few points that we have here. Excuse me. And one of those was relating to the data, which was just mentioned earlier, which is continually coming into the service, and how we use that data and what we do with it, and how we humanise the data also insofar as make it understandable and easy access. Because the way that we found that we could do that was realise that it's not only a source where we can just go into it, it's actually getting in touch with the people who provide that data to us. So the expression was given to us, get down and dirty with the data. But that's also with the people too, the people who offer up the information to us, so that then we can actually have a look towards how we might use the data and go forward with it. Part of another point that we came across was how we might change attitudes and judgments and beliefs that people have from within the services on both sides, on this belief that people might have that it's us and them, when in actual fact it's we. We are working together in order to change our health service, because we are all part of that health service. It's our health service. As the people and members of society of Great Britain, it's ours, so we own it. The importance being, though, is also to recognise that the value of walking in somebody else's shoes and seeing how it feels from their perspective, how important it is to understand from grassroots level what is going on out there. So to bring together and break the divide that's between us and them and make it we. The value that is in that is immeasurable, really. It allows people to empathise and understand what is going on within the service and with the people that are in those services. Paul?
Okay. Thank you, Kevin. So we also heard about a real need for us to join up services, to integrate services around the needs of our local communities and around individuals, and how to work in co-production with the voluntary sector, the third sector, primary care, secondary care, social care, to really make sure we have a health service that meets the needs of every single individual and ensures that everyone counts and really tackles some of those health inequalities and ensures equality for all. It was a real privilege to listen to the service users today, and thank you to Kevin, who's just been outstanding.
Thanks very much, Paula. Thanks. I'm going to invite Joe to talk about the transparency workshop. And after Joe's spoken, can I have a mic down for Tim?
Okay, thanks, Olivia. We were part of a workshop on data transparency and participation. And given the nature of the people who are interested in that, you won't be surprised to hear there were quite a lot of tweeters in there. And for those of you who weren't able to be there, there is an awful lot of tweets and proceedings and pictures and God knows what else across all the work streams that you can go and have a look at the full details of what we did and also get involved. The major themes that we came out with was around, firstly around data, was around being open about why we use it, being very careful about why we use it, and also being prescient of the need to be very, very careful about the way in which that is managed and access is controlled, but also not being frightened about the capability and the potential for that. That also fed into the discussion around mobile apps and how you can use it, and a theme that came across there and across the transparency and across the participation was the importance of putting the patient and the individual member of public right at the centre of everything that is being designed and the reasons for why it was happening. There was a degree of realism around data, and new ways of working are great and new mobile channels are fantastic, but we mustn't forget the importance of traditional ways of working, traditional ways of communicating, but also there was a role there for NHS England, partly coming on the back of what David said, about helping to explain the complexity of the NHS to people who aren't familiar with it, and helping guide them through and give them the data and the information that they need. On participation, one of the other important things was being grown up about the way in which we participate across the whole cycle, and perhaps a recognition that the NHS hasn't been great in getting in early enough and asking people at the earliest section, and then following through all the way to the end, about going back to people and saying what the results were about the feedback or input that you gave, including saying the unwelcome things and the bad things as well as the welcome things and the good things. And that was basically it.
Fantastic. Thanks, Joe. Tim, can I look to you to give your reflections, having been in the workshop and...
Yeah, no, I will look. First of all, just to thank you and Giles for and everyone who attended the workshop. It was an incredibly rich and diverse kind of set of views. But what I think I took away, and obviously NHS England, as you've heard from David and Malcolm, is massively committed towards high quality care for all, and leading to that the use of transparency, patient participation, patient and public participation is fundamental. But what I took away was a sense in which the challenge where we are now is a long way from where we want to be. I think I heard people say that they, in their experience of health services locally, they were finding lack of communication, isolation, the technology not delivering, people having to fill in endless forms, people turning up to hospital where they weren't known, repeatedly having to re-describe themselves, an NHS that doesn't remember who they are, something that in the rest of our lives would be intolerable, but in the NHS seems to be a pretty much daily occurrence for many people. So this kind of treating the patient like a customer, putting the patient in control, helping the patient and the citizen be very genuinely at the heart of the way decisions are taken was the challenge that we have not still met. So that came across really clearly. I think one specific thing that I heard as well was that there is a lot of work going on at the moment in terms of, releasing the information assets the NHS has, and genuinely creating an information revolution for patients and the public. And at the heart of that, for that to work, we need to prioritise trust. It's really important that we don't lose people who are fearful, perhaps, that we are going to, in some way, compromise their privacy or trample on their confidentiality. And I think I personally have got a lot of work to do, to just make sure that we communicate really clearly with the public and patients and everybody along the lines of, when we're going to use people's data, when we want to ask their permission to use their data, we're really clear about the purposes to which we're going to put that, and we make them really clear about their rights in relation to it. So just some quick thoughts, but thank you. What a fantastic workshop.
Thanks very much, Tim. So, and the data conversation, I think, goes into the 7-day services conversation, and Fiona gave us a fantastic vision, I think, of what we should be aspiring to. So, Fiona, over to you.
Okay, thank you. I was part of the workshop that looked at the possibility, the plan, the idea of having a 7-day NHS, and this has been engendered really from a fairly obvious point, which is that people don't have crises between 9 o'clock on Monday morning and 4 o'clock on Friday afternoon, or they do, but they have them at other times as well. And that could be a crisis where somebody feels a lump and is incredibly worried about it but can't get access to services. It might be that somebody has a stroke, obviously, or a heart attack, or some traumatic incident of some sort. And these things don't only happen between Monday morning and Friday afternoon. So the really blindingly obvious thing is that if we were going to start to design a National Health Service, we'd design a full-time NHS. We wouldn't design a part-time NHS. So we're thinking about how to get from one place to the other place, because clearly the part-time NHS isn't really working for people. It isn't just about efficiency. Clearly, having expensive machines and technologies and labs that aren't being used during the weekends is inefficient. But it's also a kind of madness to close these things down on Friday afternoon and then spend half of Monday sorting out the winding back up of the machines, of dealing with the backlogs and dealing with all the crises that have happened over the weekend and which haven't been sorted out in the meantime. So there are a number of drivers here that we're looking at. There are issues of inconvenience, which Sir Bruce talked about earlier. The business of younger people having to take time off work to bring old people to appointments, to have time off work to come and see a consultant, and generally people sitting around and doing quite expensive economic things at a cost when actually some of these services could be provided at the weekend. There's also, and this is a key thing, increasing evidence that medically the performance of hospitals over the weekends is much less good than it is during the week. Growing evidence that people who are admitted to hospitals on Saturdays and Sundays have an 11% increased risk of mortality if they're admitted on a Saturday, and 16% increased risk of mortality if they're admitted on a Sunday. That's colossal, and it's huge, and it's unacceptable. And that's without thinking about the distress caused just by stuff not happening over the weekend and being delayed until Mondays and Tuesdays. So, really, we came to the conclusion that we have to be thinking in terms that it's time to have the courage to take on a really big change within the health service. It's a major challenge. These big changes always bring with them discussions of the idea of centralisation, of centralising specialist services. And there are really, really good reasons for doing this. But also problems and issues always arise, because then you're talking about people travelling long distances and marginalising people who don't have transport, people who don't have cars, the old, the elderly, the frail, and so on, for whom localised services are even more precious than for the more able parts of society. So we also came to the idea that actually we get bogged down in this then. We get bogged down in, do we go for centralisation, or is this idea of localised services so precious that that holds all that back and we lose the gains that we might have? But actually, we thought this is probably a false division. It's a false dichotomy. And actually, we should be thinking about integrating things. The idea of integration, that the centralisation of services can work as long as other agencies are involved, as long as we're bringing in all the other parts of society that need fixing at the same time. So, not a trivial thing, evidently, but we need to be integrating primary care services so that people aren't forced into emergency care out of hours, for instance. Primary services so that people can access those at the weekend to deal with less acute difficulties. We need to be integrating social care so that people aren't sitting festering in hospitals, waiting to be discharged because there isn't social care available for them and you can't phone a social worker on a Saturday. I might be maligning social workers at that point, but you understand what I mean. And we need to ensure as well that things like public transport is available. So it isn't just about the things we've got immediate control over. It's about a lot of other agencies as well that need to be integrated on a huge scale, really, in order that we can create what should be a seamless, consistently high-level service 7 days a week. It ain't going to be easy. It's a really prickly thing to grasp, I think. But I don't think there's any option here. I think it's time we grasped it.
Fiona, thank you very much. So if I can invite Bruce to just provide his own reflections on that workshop and perhaps on Fiona's comments as well.
Fiona, thanks very much. That was a really articulate description of our discussion. My name's Bruce Keogh. I'm the medical director. And we're very keen in NHS England to be seen to be the people responsible for turning taxpayers' money into good clinical outcomes and good experience for patients. That's our raison d'etre. And to do that, we have to make outcomes and experience the currency of the way we do business in the NHS. And as we've thought about that, it's become clear to us that there are 5 things that the NHS should do. Indeed, any healthcare system should do. The first is it should stop you dying prematurely where it can. Secondly, it should look after you well when you have a long-term condition. Thirdly, it should look after you well if you need a short episode of care, such as cataracts or a broken leg. Fourthly, it should treat you well, and Tim Kelsey's already alluded to customer service. And finally, it should treat you safely. It should not increase the risk of your disease or your treatment. And we now have compelling evidence that failure to provide 7-day services in our NHS impacts on each and every one of those. While GPs' surgeries are closed, outpatients' clinics echo, the hum of expensive kit goes silent, operating theatres lie fallow, and diagnostic kit goes unused while patients wait. So I think this is a turning point for us. We've seen a number of reports both in the media and from royal colleges and institutions of medicine and nursing saying that the time is ripe for this to happen. And when enough people want something to happen, it will happen, and we will facilitate that in NHS England. Thank you.
Thank you very much, Bruce. If I can invite Malcolm to give us some comments back from the end-of-life care conversations.
Yes, one of the most emotional topics. What we felt there was a need to be clear that what words mean, particularly at that sort of time. But we're not talking about just end-of-life care, we're talking about care through the end of life. There are very inherently difficult conversations that need to be had. People need time and space so that the individual and their family can take it in. There's a need for society to find ways that we can talk more about dying and demedicalise death. It's a very, very complex issue. The priorities that we felt were essential for end-of-life care were decent communication, good education and awareness, not just within the medical profession, but within the public. The public are not aware of some of the issues that they will face. We need to make hospitals better places to die. Somebody made the point that we talk a lot about people preferring to die at home. Why is that? And we need to remember that a lot of these conditions are going to be multiple conditions. A lot of the patients will have things like dementia, frailty, and one of the things that came through very strongly was that palliative care is not just about cancer. It's about all those other illnesses. And the other point we came up with was there needs to be much better support for carers and bereavement support. These are very important issues for end-of-life discussions.
Brilliant. Thank you very much, Malcolm. Now, can I look to Jane to provide her own reflections on that workshop and some of the things you've heard today?
Thank you. My name's Jane Cummings. I'm the Chief Nursing Officer. And I think Malcolm described really well what happened at that workshop this afternoon. And for me, what really struck home was not only the complete engagement and the passion that there was from everybody in the room, but also from those that followed on Twitter. And it was another example of where there were multiple tweets around this particular subject. And I think for me, some of the overwhelming things that came through was the ability to communicate well. So Martin McShane, who facilitated or was there at the meeting, said, communication is absolutely vital. Another one that came through, both from those that tweeted and from those in the room, was about choice. We shouldn't assume where people want to go and want to die. Let's ask them. Let's listen to what's important to them and what's important to them and their families. And lastly, there was something about we only get one chance to get this right. If we get it wrong, we can't change. We can't say we'll make it better next time. There is only one chance to get it right. And if we can do that for every patient, every time, it's something that those that are left behind will always remember. I know when it works well, it works very well. I know that from my own personal experience. And I and the people in NHS England and those of us that were in that room want to make sure that that's available for everybody always. Thank you.
Thank you very much, Jane. So, Alison, your group talked about the call to action.
The thing that we talked about was the starting point was around the NHS belongs to the people. And if the NHS belongs to the people, we need to think about what that really means in order for it to mean something. And it's about thinking about people in communities as owners of the NHS. And if that's going to mean something, we need to change the relationship that we have between citizens and services. And that changed relationship will be about us seeing people as peers, as seeing people as equals, as assets, not as problems, as people who can bring something that we don't have, that they understand the community in which they live, they understand their circumstances that affect them. We need to recognise those qualities, those assets, those skills, and work with people to find a new way of working together, a new solution that brings new possibilities. And the possibilities that we've got at the moment are limited, and we haven't got sufficient resource to meet the needs that we now know that we need to face. So many of the things that we have to tackle, many of the challenges around long-term conditions, around an ageing population, they're things that are not hugely medical issues. They're things that people in communities can be part of and be partners in helping to support. So there were our conversations. We need to think about how you create that relationship. It's not something that just happens. It's something that we need to design. We need to work with service providers, with GPs, with clinical commissioning colleagues around how we work together to do things differently. There's lots of expertise across the country in lots of different places in the voluntary sector, in all sorts of areas where people have been brought in. I work with 18,000 volunteers and communities who bring their time, their creativity, their can-do attitude to do things differently. I met a group of children on Monday evening. They were aged between 13 and 20. And in that 1.5 hours that I spent with them, they had so many ideas about how they could do things differently. One child said, in her school, 10 of her people in her peer group self-harmed. She wanted to set up a group for people who self-harmed. This is not about a clever medical model. This is about just finding solutions in that community. And we can do that. We can support people to do things differently. So we believe that if you work with citizens, if you find new ways to have conversations, that you will have better health outcomes, will have better health services, and will have better commissioning decisions. And I think finally, I guess I would say, we need to just change our mental model. We need to stop thinking about what we do for people or to people, but think about how we can do things with people. And if we start from that position and start from a position of respect, then we will have a different outcome.
Thanks very much. Tony.
Following on from the call to action, and we are supposed to be outlining this future, and what we felt were fundamental things for that is that this service should be free at the point of need, and it should be accessible to all. What we felt very strongly was that we shouldn't be turning round and saying that there's certain sections of our society should not be able to access health services. And to me, those are fundamental things. Following on in respect of Alison's of this engagement, what we feel quite strongly is that the patient and their family has to be at the centre of everything. We talk about personalisation, and far too often what it means is other people doing things on their behalf or for them or imposing things, and what we don't do is actually listen to the individual. So we have to start and really do develop that personalisation to ensure that those people do have the choice, and not only within respect of their own care, but wider, so getting involved in wider issues. And in order to do that, we need to actually invest time and energy, because not everybody is able to articulate what it is that they actually want to change about in respect of their lives. So we do need to invest on that. And what we need to be very careful is we don't keep going back to the same people, because we'll get the same answers. And if we've got problems with our services at present is, I'm sorry, a lot of that's down to because we kept asking the same people or the same groups. So we've got to step out of that. And the common theme that's come out from all the groups of this recognition is, this is a national health service. It's not a national ill service. And a lot of you are aware, we're now in a lot of areas now, we've got health and wellbeing boards. And that second part of it, well-being, there's no point of actually dealing with the condition. We all have to be, at the end of the day, feel well within ourselves. And in order to deliver that, as has come out from all the groups, is we can't just rely on the NHS clinicians and staff. We have to engage with social services. We have to engage with other aspects of the local authority, environmental, various community groups within the local authority, transport, education, and that large sector, which is really the largest sector we've got, the voluntary sector. And we're very poor at doing that, yet a lot of that expertise and excellence is actually within the voluntary sector. So in order to deliver this new agenda, we definitely have to think of another way. Thank you.
Thank you very much, Tony. Can I just invite Bill McCarthy to give us one or two reflections on today?
Thanks, Olivia. I'm Bill McCarthy, the Policy Director for NHS England. Thanks to everyone who came along. It's been a fantastically rich day for us. You know, we're drawing on some real experiences and able to distill those and start putting them into practical actions. That's what we're about. I think if there's one theme that I'd pick up that I was hearing in the workshops, that I was hearing from the stage, it's this statement that the NHS belongs to the people. And our task is to turn that from a kind of a really good-sounding aspiration into a practical business model. That's what we do. And if we're going to take that seriously, that's got a set of real consequences for us. It's got consequences for our behaviours. You know, are we genuinely open to engaging with people, not just with particular patient groups who perhaps are regular voices, but a much more open set of conversations with the people in the communities who own their services? What does that mean for us? Are we going to be really brave about transparency and the accountability that brings? Everything that David was saying in his presentation at the start. Are we going to be radical enough in the scope of our partnership working? We've heard some really strong messages that it's not good enough just for different parts of the NHS to be talking to each other. We've got to understand all of those relationships with the voluntary sector, with charitable groups, with social care, with housing, and make those boundaries irrelevant for the people we're serving. Our job to simplify and join up and make sure that the aspiration for better care, a good life and full potential is met every time for everyone, whoever you are, whatever group you're from. Those are, really significant changes for us that we now need to build in to the way we work in future. So this isn't just a single really good day, really good set of conversations. The call to action is about setting that off in every locality, every community, engaging with local people, with communities, to develop the NHS that's going to be right for them. And this is not going to lead to a quiet life. This is going to be a call, I think, for some quite difficult, some quite radical changes of the sort we were hearing about with 7-day services. But there'll be changes that are driven by the people who own those services. It won't be imposed. It'll be the changes driven by the people through that engagement, which will give the best outcomes everywhere, wherever you are, all the time, from cradle to grave. And that's, for me, a really exciting aspiration. Really difficult, really challenging, but that's why we're here, and that's why I'm so grateful to all of you for coming along today.
Thank you very much, Bill, and thank you very much, Malcolm, for this opportunity to allow the voices of all those really rich discussions to be heard today. There's also been discussions going on today in Alder Hey with a group of children, young people and their families about the services that they access in their NHS in their area, and similarly a Children and Young People's Forum happening in Cambridge. So this isn't just happening here. We want these conversations to be happening all over the country. So thank you very much, everybody who's given us their time today. It's really appreciated. Thank you.